My name's Jordan Feld. I'm a hepatologist at the Toronto Centre for Liver Disease at the Toronto General Hospital, and I have been working on hepatitis C for a long time, working on new treatments, trying to figure out how to get people into treatment. The most important thing we need to do in the response to hepatitis C in Canada is screen. And the reason we need to do that is because we, as many other countries in the world, have a very large population of people living with hepatitis C that don't know they have it. And the reason for this is very simple. This is an infection that for most people is completely or almost completely asymptomatic. So you can have this infection for years, even decades, and have no symptoms at all, or have very mild symptoms, things like fatigue or a bit of brain fog, as some people tell me they have. You don't necessarily attribute those to anything, so you don't tell your doctor about it, you don't get screened, and as a consequence, you go on with this infection, and it's slowly damaging the liver. I always say to people, the best thing about liver disease is it has no symptoms, and the worst thing about liver disease is it has no symptoms. Our biggest nightmare is when we see people showing up with very advanced liver disease just after or at the time that they're diagnosed with hepatitis C. This is such a missed opportunity. That person's been living with that infection for decades by the time they come to present with a liver cancer or advanced cirrhosis. And it's really devastating because at that point, although we can still often cure the infection, the damage to their liver is already established and it's hard to reverse that. The flip side is if we can get ahead of this, if we can identify people when they have early stage disease or early stage damage to the liver without cirrhosis, if we treat them and cure them, and now our cure rates are over 95% with very easy treatment, it means we prevent them from ever developing those consequences, and we have the added public health and societal benefit that those people don't go on to transmit the infection to anybody else. And the statistics in Canada are pretty alarming, that if you look at, most estimates would suggest that at least 45% of the population living with hepatitis C have not been diagnosed, and some studies suggest that it's as high as 70%. That means that more than 2/3 of people with this infection don't know they have it, and the only way we're going to identify them is by screening. Traditionally, we've focused our testing for hepatitis C on people with risk factors, and although this sort of makes sense, you think, well, you got to get it somehow, we may as well focus on people that have a risk factor. The problem with that is that we don't do it very well. So we've got to expand that, and we really cannot continue with our current strategy of just testing people based on risks. We need to look into the population and recognize that at least some of the times we're not good at assessing risks. People don't always want to talk about some of their risks. If you're in a busy family doctor's office, they got lots of things to talk to you about, and they may not want to talk to you about drug use or a blood transfusion or some other exposure that you had 25 years ago. So if we focus on the risks, we end up missing a lot of people, and that's why we've really encouraged the government to go to a more public health approach to this and to do broad-based population screening. And you can think of this in different ways. So you identify groups in the population that have a higher burden or higher prevalence of hepatitis C. And in Canada, similar to the US, we should be screening so-called baby boomers. And the US developed this, instituted it starting in 2012. And the reason they did this is they found that of people with hepatitis C living in the US, 75% of them happen to fall into the age range of people born between 1945 and 1965. Canada, it's a little different, so we should be expanding that testing just a little bit from 1945 to 1970 or 1975. But if we do that, we're going to get probably 70% or so of the people with hepatitis C infected in the population. And the other nice thing about screening that way rather than screening based on risks is it really destigmatizes screening. One of the things I hate about screening when we do it risk-based is it makes people think that hep C is just a disease of drug users or a disease of immigrants or a disease of hemophiliacs or whatever group you want to specify. And here, when you walk into my office and I say to you, what year were you born? And then I say, based on that, just like we should check your blood pressure or your cholesterol, we should check you for hepatitis C. That's a much easier interaction, and certainly if it turns out that you test positive, we should explore the fact that you may have had some risk exposures in the past, because they may have some health consequences and we should talk about them. But it's a good entry, it's a much easier entry to that discussion, and frankly the biggest thing is that it's going to help us identify so many people living with hepatitis C that don't know they have it. So it was very disappointing for many of us in this field to see the Preventative Task Force come out with recommendations earlier this year about hepatitis C screening. And unfortunately, the task force went through the existing data. Now, they did come to one part of the conclusion I agreed with, which was that the data are not very good in Canada. We don't really know how much hepatitis C is here, how many people are living with this infection in the country. And because of that, but unfortunately not only because of that, they came up with a recommendation that we should not screen people at low risk for hepatitis C. That's almost a silly recommendation when you think about it. Of course we shouldn't screen people at low risk for hepatitis C. The big problem is that we're not very good at identifying who's at low risk for hepatitis C. So if people walked around with a C on their forehead and I knew you're at high risk, you're at low risk, I would know who to test, but I don't have that information. So the idea that they recommended that is not a very useful recommendation. And then they went on and they broke it down and they talked about why they didn't advocate for birth cohort or some other type of population-based screening. And frankly, I was very disappointed in the quality of the guideline. I think they misinterpreted a lot of the evidence, and I could go through this in great detail, but just to highlight a few of the points they made. So one point they made is that if we screen people and we can't get them treatment, then we're not helping them. And I think that's a fair point. But then we shouldn't screen anyone. We shouldn't just not screen baby boomers. So why is it okay for someone to screen someone who has a history of drug use for hepatitis C if I can't offer them treatment? And it's not okay to screen a baby boomer for hepatitis C if I can't offer them treatment. Both of those people deserve treatment. We definitely need to improve access, but I don't understand why that would be an argument to not advocate for screening. Then a few other things. They underestimate the value of cure. They really look at the short-term benefits and not the long-term benefits. They also underestimated the burden of this disease. They looked at the fact that all the textbooks quote that 20% of people develop cirrhosis. What they didn't mention is that that's at 20 years of infection. Many people have had this infection for a lot longer than 20 years. They acquired it as a kid through unsterilized medical equipment. They acquired it through injection drug use in their teens or their 20s. We're seeing them 20, 30, 40, 50 years later. And when you start looking at the lifetime risk of cirrhosis, it's much, much higher than that 20% number. It's probably in the range of 50 to 60%. So they underestimate the benefits, underestimate the risks and then they talk a lot about the cost of treatment, which unfortunately, A, they got some of the numbers wrong, but B, to talk about the cost of treatment and not talk about the cost of no treatment is really not a very scientific way of looking at medical costs. It's a pretty standard thing that you look at the costs of the intervention and you look at also what are the costs of not intervening. And what are those costs? Well, those costs are that people continue to live with their infection, they develop progressive disease, some of them go on to need expensive treatments like liver transplants, and perhaps the biggest cost is that many of them unwittingly may go on and spread the infection to other people because they don't even know they have it. If you don't consider those costs, then yeah, the cost of the treatment's expensive. I'm not justifying the cost of the treatment, they're too expensive, but you have to put it into the context of the cost of not treating. And what's clearly shown is that screening and treating for hepatitis C is cost effective even at the high prices of the current drugs. And if we could get those prices down, and we are getting them down, it could be cost saving, so that every time we screen and treat someone for hepatitis C, we actually save the healthcare system money. So if we fail to address this now, the costs are going to be massive because we are seeing a clear aging of the population. Many people acquired this infection decades ago and they now have had the infection for 20, 30, 40 years. They now have cirrhosis, more advanced liver disease, and those people are starting to develop extremely costly complications. So people talk a lot about the costs of these therapies, but a couple of things about that. Again, I'm not going to justify the cost, they're too high, but this is curative treatment. So this is not like for most other chronic diseases where someone goes on a treatment that they may take for many, many years. This is a treatment that's taken for a finite time, 2 or 3 months. It's very quick, and then the person's finished and they're cured 99% of the time. So that doesn't happen in most other things, and it's important to put that into the context when you think about the cost. And then you need to think about the fact that you're preventing all of these downstream costs of managing the complications of the liver disease, and perhaps even most importantly is you're preventing new infections. So every time we treat somebody, particularly when we treat people at high risk of transmitting the infection, so people who are using drugs or people who are engaged in other high-risk activities, when we treat those people, we not only give them benefit to their own health of having been free of hepatitis C, but they don't pass that on to the infection to other people, and that saves us all money in the long run because we don't have to treat those individuals, and they don't pass it on to anyone else, and they don't get long-term consequences that are very costly to our healthcare system. If we don't scale up testing and the whole cascade of care, not only testing, but identifying people when they're positive and making sure that they get the care and treatment that they need, we are going to be dealing with a massive burden of illness. We're already seeing rising rates of cirrhosis, rising rates of complications of liver disease, increased hospital admissions, increased rates of liver cancer, and all of these things are to do with the fact that the population with hepatitis C is aging in Canada, and if we don't identify these people now, this will continue to escalate and have a huge both health and financial burden on the country. And the other thing is that it will make us a bit out of step with the international community. The World Health Organization has called for the elimination of viral hepatitis as a public health problem by the year 2030. Canada, as one of her first acts as the Minister of Health, Jane Philpott, signed on to those commitments with the World Health Organization. I was very proud that Canada signed on to that, but now we have to follow that signature up with some action. We need a strong action plan, which is going to involve screening, but it doesn't end at screening. We have to make sure that we have all of the infrastructure that once we identify people, we get them the care they need, and we build in, it's not just about the infection, it's also about some of the things that go along with hepatitis C. So we have to build things like harm reduction into that so that we make sure that we don't have new infections with hepatitis C, not just that we treat all those people who are already infected.